Hi, my name is Boyana. I'm a student physical therapist. The patients in this video will be Mariah and Danny. We will be going over several screening assessment techniques, including auscultation palpation for abdominal aortic aneurysm, upper extremity and lower extremity fracture screening using percussion and auscultation for the clavicle, proximal humerus, and femur, fracture screening with a tuning fork on the navicular bone, and 2 cranial nerve eye exams, the pupillary reflex and tracking and convergence. All right, let's dive in. This assessment should be performed sitting down, with eyes at a good level to the abdomen. However, due to the table not being adjustable and an appropriate chair height to the examiner not being found, better use of body mechanics was made possible standing up. Please note, however, for optimal visual results and body mechanics, usually the test should be performed sitting. The assessment for an abdominal aortic aneurysm usually starts with observation. Do we see a pulse? Usually this is more possible with thinner patients who have their legs extended out. This is possible due to the blood vessel being not far from the belly wall. If a AAA were to be visible, it would most likely be along the area of the umbilicus, where the abdominal aorta is most superficial in relation to the belly wall. After we have visually examined for a pulse, we can begin to perform palpations. We will begin midline in the epigastric area, off to the left a little bit, and using the flat pad of your hands, not the fingertips. You will advise the patient that as you apply pressure to let you know if any of their symptoms change for the better or worse, or if they even seem to feel more than just pressure. You begin midline in the epigastric area and palpate down toward the umbilicus. Once you reach the top of the umbilicus, you will bifurcate, moving over each of the common iliacs. You can imagine an imaginary line from umbilicus to iliopsoas, and the iliacs will tend to follow that line. As you come about a quarter of a third of the way down, move from one side to the other, comparing sensations, and then again slightly further down. Normal diameter is up to 3 centimeters, women between 2 to 3. Any diameter felt larger than 3 centimeters under the fingers is considered an aneurysm. When palpations are performed, a majority of people with an aneurysm will present asymptomatic, meaning there is no pain or any symptoms. But there are some that may report having a dull, diffused, pounding backache. If greater tenderness is provoked during palpations, the results are even more alarming as the blood vessel wall may be presenting with greater irritation. So to summarize so far, seeing a pulse and feeling a pulse no larger than 3 centimeters in diameter is normal. However, one should never hear a pulse. The next part of the AAA assessment is to perform auscultations following the same path as the palpations. You want to ensure that you have a firm pressure and full contact with the skin, but ensure you are not making a dent. This is very important because applying too much pressure and creating a dent can result in flattening the vessel and creating turbulent blood flow, giving a false positive result. That would be due to obturator error. So make sure no dent in the belly wall is made. Start high by the renal arteries down towards the umbilicus and then over the common iliacs. If turbulent blood flow is heard with proper technique, no dent, over the abdominal aorta, the sound is called a bruit, and is indicative of the likelihood of a AAA being present. The purpose of this auscultation and palpation assessment is that it is commonly used screening tool for AAA. Individually, the tests don't yield the most statistically sounding results. However, auscultating has great specificity and palpation has great sensitivity. Together, the two can greatly eliminate chances of false positive and negatives and a good indication of the presence of a AAA. To assess for potential fracture in a long bone, we can use a special screening test that combines auscultation and percussion to selectively stress or screen a particular bone, in our case the femur, clavicle, and proximal humerus. These will be sound tests, not pain tests, and the sharp or dull sound heard through the stethoscope will differentiate to the PT whether there is a suspected stress fracture or not. Normal unfractured bone will have a very clean, distinct sound. Bone with a defect, like a fracture, will present with a more muffled, diffused, washed-out sound. Normal bone will be like directly knocking on your door. Fractured bone would be hearing a door knock 2 doors down. You hear a knock, but it is more muffled compared to the direct knock. This technique will work for any long bones in the body. Once you determine which bone you want to assess, find its corresponding flat bony prominence to apply the stethoscope. You will always begin by assessing the uninvolved side first, then assess the involved side for comparison. You will want to perform 2 consecutive solid taps 3 times in repetition on each side for sufficient evaluation. Due to trying to create optimal view for the viewer, some of these subsequent facts may not be represented accurately, but ensure you follow the following. You will always want to perform the tap towards yourself and always use your dominant hand. This allows a solid, steady tap. When you perform the percussion, ensure you are using your fingertips, not the finger pads, and snap down firmly through your wrists. Head and neck of the femur stress fractures are commonly missed. The bones are too deep to have success with simply palpating the area. For assessment of head and the neck of the femur, we would place the stethoscope midline over the pubic symphysis and perform our percussion on the patient's patella. We will begin by instructing the patient to find their belly button and move their fingers down until they feel the bony prominence. Once the patient states they have found the spot, the examiner can confirm and then instruct the patient to place the stethoscope over the pubic symphysis. Advise the patient to not cover the top portion of the stethoscope with their fingers, but to hold it down firmly. Stethoscope sounds can be assessed through a thin layer of clothing, but not over a zipper or button. The patient will hold the stethoscope in place while the examiner percusses each patella, first the uninvolved side, followed by the involved side, and then evaluate their findings. You want to ensure you are hitting both patellas in the center. Grab the patella with the thumb and index finger and pull the skin down. This will allow better approximation and give the examiner an easier target to aim for. This will essentially help minimize operator error. Both legs should be extended symmetrically when doing the test. This test is most commonly used to assess head and neck of the femur fractures, but technically is screening everything between the pubic symphysis and the patella. This test will not tell us what type of fracture is present, just that there is a chance of a fracture being present. The same principle of percussion and auscultation is applied to screen the clavicle and proximal humerus as was with the head and neck of the femur, just instead using their appropriate bony landmarks. The stethoscope is placed at one flat end of the bone and tapping percussing on the other end of the bone. Normal unfractured bone will have a very clean, distinct sound. Bone with a defect like a fracture will present with a more muffled, diffused, washed out sound. For the upper shoulder girdle area, clavicular fractures, they are unusual to be missed because the bone is very superficial. Proximal humerus fractures, however, can be missed at times, and due to all the nerves and arteries that run close, we don't want to miss this one. So the stethoscope will be placed over the manubrium. Begin by finding the sternal notch, drop right below that, and there will be the manubrium. Either have the patient or examiner hold the stethoscope over the manubrium. The area you will be percussing over is just distal to the olecranon. You don't want to go proximally because that will elicit a triceps reflex. You will place the patient's elbow in a 90-degree flex position and tap firmly twice on the distal olecranon 3 times and then switch to the involved side. Remember to do the uninvolved side first, then the involved side. The arm can either be held up bent at 90 degrees or it can be resting on the patient's chest at also 90 degrees. This assessment will screen anything between the manubrium through the humerus. If you are more confident your fracture is located in the proximal humerus, the stethoscope can be transferred to the flat part of the acromion and then again percuss on the distal olecranon. In order to do this, ensure both the patient's acromions are flat enough in order to properly place the stethoscope and assess for a potential fracture. Next, we are going to demonstrate how to assess for a fracture using a tuning fork in some of our smaller bones like the navicular, which we will be showing in this video. Unlike long bones radiating the percussion sound into the stethoscope, smaller bones will elicit a greater feeling of pain when touched with a tuning fork if a fracture is present. A rule of thumb when using tuning forks to rule out fracture is that if the area is too deep to be palpated, most likely it is too deep to be assessed with a tuning fork. Some other general tips is that the tuning fork needs to have a good hit to create a good flow of vibrations. You can use the heel of your hand or the sides of a table. Another thing is to find the bony landmark prior to hitting the tuning fork as to not let the vibrations dissipate before application. Lastly, you do not want your fingers anywhere on the actual fork part of the tuning fork. Ensure your fingers remain on the stem and nothing is making contact with the top portion of the tuning fork. Once the bony landmark is identified, apply a force to the tuning fork, elicit a vibration, and then firmly place the stem flat on the bone you are assessing. In this video, we will be demonstrating a tuning fork screen for the navicular. Plain films are known to commonly miss fractures in the tarsals and carpals. To locate the navicular, find the medial malleolus and drop down towards the toes until the next most prominent bony surface is felt. This will be your navicular. Apply the step mentioned above. Locate the navicular bone, hit the tuning fork, hold by the stem, do not obstruct the actual fork, and then firmly place the stem onto the navicular. The assessment should first be performed on the uninvolved side to show the patient what the feeling that they are expecting should be. Then the involved side should be tested. If the application of the tuning fork elicits a greater pain, the potential for a fracture is noted. This test should only be performed once unless necessary to avoid causing further pain to the patient. If no increased pain or discomfort is noted, a fracture is less likely. Pupils should be round and similar in diameter. If during examination you notice one maybe looks larger or maybe notice signs of ptosis, you would perform the pupillary light response test. Testing this reflex will incorporate examining proper function of both the second and third cranial nerves. The movement of the light to and from the eyes tests for afferent pupillary defects. Noted asymmetry would indicate a defect in either the optic or ocular motor nerve. If the pupil's constriction response and dilation response back to normal is quick, about 3 seconds, then a lesion in either the optic or ocular motor nerves is not a concern and both nerves are functioning properly. It is common for people to present with some facial asymmetry, both in the eye musculature and pupil size. That may cause you to note the asymmetry. However, if asymmetry, a delay, or lack of constriction return in either eye is noted, then a lesion in either cranial nerve may be present and the patient should be referred to an appropriate physician. When you swing the flashlight in front of the eye, the pupil should constrict briskly. Light goes out and the pupil should return back to normal size almost as briskly. In order for it to be a valid test, one must ensure the light stimulus only gets into one eye, and each eye must be tested twice to properly complete this test. Place the heel of your hand right over the bridge of the patient's nose. Instruct patients to look straight ahead, behind to a farther distance. If the patient looks too close, pupils may not change. A constriction won't occur, and you may believe you received a positive finding when it really is just the natural focusing of the patient's eyes. Once the patient is looking straight ahead, turn the flashlight on and keep it on. Begin by swinging it in front of one eye, hold it until the pupil constricts, count the seconds it takes. It should be about 3, and then as soon as the pupil constricts, remove the flashlight and wait to see the pupil return back to normal. Again, count the seconds. This is testing the direct response. Now we will repeat the same steps, except we will monitor the constriction and return to normal in the eye not receiving the light stimulus, and we should receive the same results. We will repeat both measures twice, and then move on to testing the opposite eye the same way. When you are observing the eye with a direct stimulus, this is testing the direct response. When testing the one not receiving the stimulus, this is the indirect response being tested. If a patient is presenting with strabismus, malalignment of the eyes, meaning rather than both eyes giving direct locked contact, one eye is a little bit off in some direction. This should not be immediately alarming. Some individuals have experienced this since infancy and are being properly treated. However, some may have a more spontaneous onset with reported double vision, making your findings more alarming to a potential unknown impairment in either the ocular motor nerve, abducens nerve, or trochlear nerve. The tracking movements test is used to examine these 3 nerves that control the musculature around the eyes and allow us to hold steady gaze in both eyes in specific directions. Cranial nerve 3 mediates medial deviation and all other directions of movements not coordinated by cranial nerves 4 and 6. Cranial nerve 4 innervates the superior oblique muscle and mediates medial downward gaze. Cranial nerve 6 innervates the lateral rectus and mediates lateral gaze. Observing convergence, moving the object directly between the 2 eyes, is done at the end of the exam. This will indicate proper functioning of the medial rectus muscle and cranial nerve 3 innervation. If the patient is able to track all movements smoothly and consistently, then cranial nerves 3, 4, and 6 are intact and properly functioning. However, if in a certain direction one eye doesn't appear to follow the proper pursuit and remains lagging in a specific gaze, that must be assessed to determine which motion, musculature, and subsequent cranial nerve is impaired and not performing adequately. If a degree of malalignment is present but stays consistent no matter which direction the eyes are in, this is probably a non-worrisome strabismus called a concomitant strabismus. However, if the degree of alignment varies considerably, depending which direction the eyes are moving in, this is more alarming and could be a potential fracture or a mass occupying space in the orbit and affecting one of these nerves. The directions you will give the patient is something along the lines of, I want you to follow the tip of my pen as I move it in different directions. Try not to move your head at all and only follow it with your eyes. Position the pen light about 9 to 12 inches away from the face. If it is too close, you will get an abnormal finding. As you have the patient track the tip of the pen light, observe the positioning and tracking of the patient's eye movements. You will draw out what appears to be a figure H pattern, but realistically what you are doing is assessing the ability of the patient's eyes to track the two upper and lower corners, track directly laterally across, and then an immediate convergence to the center of both eyes. My H here is a little wide, a little skewed off. I tried to make it as visible for you all to see, but ensure your H is large enough to assess the peripheral motions of the eye, but not so wide that the patient is needing to turn their head to see the pen light. I would like to thank Dr. Pashun and Dr. Boysenall for the information and guidance they provided to complete this video. Thanks for watching, everyone.